My name is Andrew Ditch. I am sharing a video on what could be the cause of self-care issues. I will let you be the one to judge off of my appearance and recent videos in my past videos. What causes self-care deficits? Considering citation structure. Okay, so for the answer, it seems clear I should use a single citation at the end of the whole piece, but also follow the guideline of giving a citation for each piece of information from my search results. I could place citations at the end of each paragraph, ensuring the sequence stays in order. I'll organize things in 3 paragraphs with an overview, then separate into causes like physical, neurological, and cognitive. Each one will end with the proper citation. I'll keep things concise and ensure it flows well. Causes of self-care deficits. Self-care deficits arise when a person cannot independently perform activities of daily living, ADLS, such as bathing, dressing, toileting, feeding, and mobility. These deficits can be temporary, post-operative or acute illness, or chronic, progressive disease or long-standing disability. Physical and neurological causes. Muscle weakness, fatigue, or poor mobility, arthritis, deconditioning. Neuromuscular and neurological disorders, stroke, spinal cord injury, multiple sclerosis, Parkinson disease. Sensory impairments and pain that limit safe movement or fine motor tasks. Recent surgery, fractures, or acute medical illness that temporarily reduce ability to perform ADLS. Cognitive, psychiatric, developmental, medication, and environmental causes. Cognitive impairment, dementia, traumatic brain injury, intellectual disability, that reduces planning, sequencing, memory, or problem-solving needed for ADLS. Depression, anxiety, severe apathy, or motivational deficits that reduce initiation of self-care. Developmental disabilities and communication differences that affect learning or performing self-care without supports. Medication side effects, sedation, dizziness, anticholinergic effects, that impair function. Environmental and social factors, lack of adaptive equipment, inaccessible home layout, low caregiver support, or poverty that block independence in ADLS. How this helps assessment and planning. Identifying the contributing cause, S, guides what to do next, rehabilitation and mobility aids for physical causes, cognitive assessment and task simplification for cognitive causes, mental health treatment and behavioral supports for psychiatric causes, and home adaptations or caregiver training for environmental barriers. What are all mental disabilities cause self-care deficits? Considering self-care deficits and mental disabilities. The user is asking about mental disabilities that lead to self-care deficits. There's a long list to consider, like psychiatric disorders, neurodevelopmental issues, neurocognitive disorders, intellectual disabilities, and autism spectrum disorder, just to name a few. Many of these conditions, such as schizophrenia, OCD, or severe anxiety, affect areas like cognition, motivation, and executive function, leading to self-care challenges. Understanding this involves thinking about mechanisms like apathy, self-neglect, hallucinations, and negative symptoms which interfere with self-care. Mental disabilities that commonly cause self-care deficits. Below is a practical, non-exhaustive list of mental, neurodevelopmental, and neurocognitive conditions that frequently lead to difficulties with activities of daily living, ADLS, and other self-care tasks. Major neurocognitive disorder, dementia, progressive memory, orientation, and executive dysfunction that impairs planning, sequencing, and safety for ADLS. Intellectual disability, lifelong limitations in intellectual functioning and adaptive skills that can reduce independence in bathing, dressing, feeding, and toileting. Autism spectrum disorder, with support needs, differences in adaptive skills, sensory sensitivities, rigid routines, communication, and learning that can limit independent self-care without supports. Schizophrenia and other primary psychotic disorders, negative symptoms, avolition, social withdrawal, cognitive deficits, and positive symptoms, delusions, hallucinations, that reduce initiation and performance of self-care. Bipolar disorder, severe or during episodes, mania or depression can disrupt judgment, energy, and motivation needed for safe self-care. Major depressive disorder, severe, psychotic, or with marked apathy, low energy, psychomotor slowing, poor motivation, and neglect that impair ADLS. severe anxiety disorders and agoraphobia, avoidance and fear that prevent leaving home or using shared facilities and can block routine self-care. Obsessive-compulsive disorder, severe rituals that interfere with efficient self-care or avoidance of tasks because of contamination fears. Severe substance use disorders, intoxication, withdrawal, cognitive impairment, and neglect that impair hygiene, nutrition, and medical adherence. Traumatic brain injury and acquired cognitive disorders impair attention, memory, planning, and motor skills necessary for ADLS. Attention deficit hyperactivity disorder, severe, with executive dysfunction, disorganization and poor planning that can create chronic self-care gaps. Severe personality disorders, when comorbid with mood or cognitive impairment, interpersonal conflict, self-harm behaviors, or chaotic lives that undermine consistent self-care. Severe eating disorders, physical and cognitive effects, and avoidance of eating-related activities that compromise nutrition and self-monitoring. Common mechanisms linking these conditions to self-care deficits. Cognitive impairment, memory, attention, executive function, reduces sequencing, planning, and error correction. Motivational and volitional problems, apathy, avolition, depression, decrease initiation of tasks. Psychotic symptoms or disorganization interfere with reality testing and safe task completion. Sensory or motor impairments and medication side effects limit the physical ability to perform ADLS. Environmental and social factors, poverty, isolation, lack of supports or adaptive equipment, interact with diagnoses to produce or worsen deficits. Comorbidity of cognitive, physical, and psychiatric problems multiplies risk for self-neglect and ADL impairment. How to assess presence and cause of self-care deficits. Screen basic ADLS and instrumental ADLS with standardized tools and direct observation. Watch a task being done. Assess cognition, memory, attention, executive skills, mood, psychosis, substance use, and physical limitations. Review medications and side effects, and check for environmental barriers or lack of adaptive equipment. Brief guidance for intervention, matched to likely causes. For cognitive/executive problems, simplify tasks, use prompts, cueing, schedules, environmental supports, and cognitive adaptation training. For motivational/affective causes, treat underlying depression or bipolar symptoms, use behavioral activation and supported routines. For psychosis/disorganization, optimize psychiatric treatment, reduce environmental distractions, use structured coaching. For physical or motor limits, provide adaptive equipment, physical or occupational therapy, and home modifications. For social/environmental drivers, connect to community supports, case management, and caregiver training. If you want, I can, 1. Turn this into a one-page clinician summary listing screening questions and brief interventions. 2. Build a task-by-task observation checklist you can use during an assessment. Or, 3. Draft short scripts for staff to use when prompting someone through an ADL. Which would help you most? What is differential diagnosis between major neurocognitive disorder, intellectual disability, autism spectrum disorder, with support needs, schizophrenia and other primary psychotic disorders, bipolar disorder, severe or during episodes, major depressive disorder, severe, psychotic, or with marked apathy, severe anxiety disorders and agoraphobia, obsessive-compulsive disorder, severe substance use disorders, traumatic brain injury and acquired cognitive disorders, attention deficit hyperactivity disorder, severe, with executive dysfunction, severe personality disorders, when comorbid with mood or cognitive impairment, vs. severe eating disorders and key differences in symptoms. Differential diagnosis, overview. Below is a focused differential diagnostic guide comparing the listed conditions with emphasis on the features that most directly affect self-care. For each disorder I give, hallmark symptoms, how it commonly produces self-care deficits, and the key features that help distinguish it from the others. Major neurocognitive disorder, dementia. Hallmarks: gradual decline from a prior level of cognitive functioning in one or more cognitive domains, memory, executive function, language, visuospatial, attention, with loss of independence in everyday activities. How it causes self-care deficits: progressive impairment in memory, sequencing, judgment and problem-solving, forgetting to bathe, unsafe cooking, dressing errors. Key distinguishing features: later life onset, usually, documented decline from previous baseline, progressive course, preserved developmental history, objective cognitive testing shows decline, functional deterioration is out of proportion to psychiatric symptoms. Intellectual disability. Hallmarks: onset in the developmental period, before age 18, deficits in intellectual functioning, reasoning, problem solving, and adaptive functioning, communication, social, self-care. How it causes self-care deficits: lifelong limited adaptive skills and learning, may never acquire independent ADL skills without teaching and supports. Key distinguishing features: static/lifelong pattern, not a decline, history of early developmental delays or school/learning problems, IQ and adaptive behavior testing supportive, absence of a prior period of normal functioning followed by decline. Autism spectrum disorder, with support needs. Hallmarks: early neurodevelopmental condition with persistent deficits in social communication/interaction and restrictive, repetitive behaviors or sensory differences. How it causes self-care deficits: sensory sensitivities, rigid routines, executive function and motor planning difficulties, communication barriers, learned lack of skill rather than progressive loss. Key distinguishing features: early onset, social communication profile, eye contact, reciprocity, special interests, characteristic repetitive behaviors or intense sensory avoidance. Difficulties may improve with teaching but are not degenerative. Schizophrenia and primary psychotic disorders. Hallmarks: psychosis, delusions, hallucinations, disorganized thinking/behavior, negative symptoms, avolition, flat affect, and cognitive impairment variably present. How it causes self-care deficits: negative symptoms and disorganization reduce initiation and ability to carry out ADLS. Psychosis can lead to neglect or unsafe behavior. Key distinguishing features: prominent psychotic symptoms, particularly ages late teens to 30s, fluctuating insight, presence of formal thought disorder, not defined by a lifelong developmental pattern, may have episodic course with chronic residual symptoms. Bipolar disorder, severe or during episodes. Hallmarks: discrete mood episodes, manic/hypomanic episodes, elevated/irritable mood, increased energy, and depressive episodes. How it causes self-care deficits: during severe depressive episodes withdrawal, psychomotor slowing, neglect, during mania impulsivity, poor judgment, risky behaviors that compromise self-care. Key distinguishing features: episodic mood changes with periods of relative normalcy, clear mood episode timing and history of mood elevation/irritability, family history of mood disorder common. Major depressive disorder, severe, psychotic, or with marked apathy. Hallmarks: persistent low mood, anhedonia, decreased energy, cognitive slowing, worthlessness, can include psychotic features. How it causes self-care deficits: low motivation, psychomotor retardation, neglect of hygiene, poor appetite, decreased ability to plan. Key distinguishing features: prominent pervasive low mood and anhedonia, temporal relationship of decline with mood episode, improvement with antidepressant/psychotherapeutic treatment supports mood-driven cause. Severe anxiety disorders and agoraphobia. Hallmarks: excessive fear/worry, physiological arousal, avoidance behaviors. Agoraphobia causes avoidance of public places or leaving home. How it causes self-care deficits: avoidance prevents accessing facilities or services, overwhelming anxiety can block initiation of tasks, example fear of bathing due to panic. Key distinguishing features: anxiety and avoidance are central, tasks can be performed when anxiety is reduced or when supported, no global cognitive decline or lifelong developmental pattern. Obsessive compulsive disorder, severe. Hallmarks: obsessions, intrusive thoughts, and/or compulsions, repetitive rituals, that are time-consuming or cause significant distress. How it causes self-care deficits: rituals may consume time and interfere with efficient ADLS, or contamination fears may lead to avoidance of some activities. Key distinguishing features: presence of ego-dystonic obsessions and ritualized compulsions, insight varies, behaviors are driven by anxiety reduction, not by cognitive decline or psychosis. Severe substance use disorders. Hallmarks: compulsive substance use despite harm, intoxication/withdrawal signs, neglect of responsibilities. How it causes self-care deficits: intoxication or withdrawal reduces capacity, chaotic lifestyle and prioritizing substance use over hygiene, nutrition, and medical care. Key distinguishing features: temporal association between substance use and functional decline, improvement in ADLS often seen with sustained abstinence, toxicology, withdrawal signs, and social history point to substance cause. Traumatic brain injury, TBI, and acquired cognitive disorders. Hallmarks: acute injury history with subsequent focal or diffuse cognitive, behavioral, motor, or sensory deficits. How it causes self-care deficits: deficits in attention, memory, planning, motor skills, or mood/behavior after the injury impair ADLS. Key distinguishing features: clear temporal link to an injury/insult, imaging/neuropsychological profile consistent with focal deficits, sometimes stepwise or non-progressive unless secondary degenerative process. Attention deficit hyperactivity disorder, severe, with executive dysfunction. Hallmarks: inattention, poor sustained focus, impulsivity, and executive dysfunction beginning in childhood. How it causes self-care deficits: chronic disorganization, poor task initiation, forgetfulness, inconsistent routines leading to missed ADLS. Key distinguishing features: lifelong history since childhood, even if recognized later, variability of performance, improvement with organizational supports or stimulant treatment, not primarily psychotic or progressive cognitive decline. Severe personality disorders, with comorbid mood/cognitive impairment. Hallmarks: enduring maladaptive patterns of thinking, feeling, interpersonal behavior, and impulse control, typically starting by early adulthood. How it causes self-care deficits: instability, chaotic behavior, self-harm, neglect, or secondary substance use can interfere with consistent self-care. Key distinguishing features: pervasive interpersonal style and identity features across contexts, patterns are stable over time rather than episodic decline, diagnosis rests on long-term behavioral pattern rather than acute cognitive loss. Severe eating disorders. Hallmarks: distorted eating behavior and body image, an BN, OSFT, with medical and cognitive effects from malnutrition. How it causes self-care deficits: severe malnutrition leads to fatigue, cognitive slowing, apathy, poor self-monitoring and physical inability to perform ADLS. Behaviors: avoidance of eating, ritualized meal behaviors, interfere with normal routines. Key distinguishing features: marked disturbances in eating/body image, significant weight/medical complications, and behaviors centered around food and weight. Nutritional markers and eating behavior history are central. Practical diagnostic clues, quick checklist. Onset and course: lifelong/early rightward arrow intellectual disability, ASD, ADHD, personality disorder, acute/after injury rightward arrow TBI, progressive decline in older adult rightward arrow neurocognitive disorder, episodic rightward arrow mood/psychotic/substance disorders. Primary symptom domain: memory/executive decline rightward arrow neurocognitive/TBI, developmental social communication deficits rightward arrow ASD, psychosis rightward arrow schizophrenia, mood elevation/depression rightward arrow bipolar/depression, obsessions/rituals rightward arrow OCD, disorganization/negative symptoms rightward arrow schizophrenia vs severe depression. Response to structure/support: if problems improve with prompting, cueing, environmental modification rightward arrow executive dysfunction, ADHD, anxiety, ASD supports, progressive non-response to cueing rightward arrow neurocognitive disorder. Course with abstinence/treatment: improves with detox rightward arrow substance related, improves with mood stabilization/antidepressant rightward arrow mood disorder, persistent despite treatment rightward arrow consider primary neurodevelopmental or neurocognitive cause. Brief assessment steps to separate diagnoses. Obtain detailed timeline, age at onset, course, any clear precipitating events. Collateral history, developmental milestones, school history, occupational function, recent changes. Mental status exam, orientation, memory, thought content, thought form, mood, insight. Cognitive testing, MoCA/MMSE, formal neuropsych when indicated. Screen for psychosis, mood episodes, substance use, medical contributors, and medication effects. Consider neuroimaging and labs when acute decline, focal signs, or reversible causes suspected. Red flags that require urgent attention. Rapid functional decline over days, weeks. New psychosis with impaired self-care or safety risk. Suspected severe malnutrition, dehydration, or inability to meet basic needs. Acute confusion, focal neurologic signs, or signs of intoxication/withdrawal. If you want, I can now create a one-page clinician differential checklist organized by the quick assessment steps above, or build a task-by-task observation form that links observed ADL errors to the most likely diagnostic categories. Which would you prefer? What is differential diagnosis between major neurocognitive disorder, intellectual disability, autism spectrum disorder, with support needs, schizophrenia and other primary psychotic disorders, bipolar disorder, severe or during episodes, major depressive disorder, severe, psychotic, or with marked apathy, severe anxiety disorders and agoraphobia, obsessive-compulsive disorder, severe substance use disorders, traumatic brain injury and acquired cognitive disorders, attention deficit hyperactivity disorder, severe, with executive dysfunction, severe personality disorders, when comorbid with mood or cognitive impairment, vs. severe eating disorders and key differences in symptoms and causes of self-care deficits. Give examples of real-life situations for each diagnosis and how they present differently for a differential diagnosis. Differential diagnosis, quick summary. This guide contrasts major diagnoses that commonly produce self-care deficits, highlighting core symptoms, how each causes self-care problems, key distinguishing features, and a short real-life example showing how it presents differently from others. Major neurocognitive disorder, dementia. Core features, acquired, progressive decline in one or more cognitive domains, memory, executive function, language, visuospatial, with loss of independence. How it causes self-care deficits, forgetting steps or that tasks need doing, impaired judgment and safety, leaving stove on, dressing improperly, poor sequencing of multi-step ADLS. Distinguishing clues, later life onset, documented decline from a previously higher level, progressive course, objective cognitive decline on testing. Example, an 80-year-old who used to manage bills and cooking now repeatedly forgets meals, wears the same clothes for days, and becomes unsafe with the stove. Family reports gradual decline over 18 months. Intellectual disability. Core features, onset in the developmental period, lifelong limitations in intellectual functioning and adaptive skills, including self-care. How it causes self-care deficits, skills were never fully acquired, requires teaching, prompts, and permanent supports rather than expecting spontaneous independent performance. Distinguishing clues, early developmental history of delays or school difficulties, stable, non-progressive, pattern, IQ/adaptive behavior testing supportive. Example, a 25-year-old with lifelong learning needs who never learned to tie shoes or cook independently, performs ADLS reliably only with stepwise teaching and supervision. Autism spectrum disorder, with support needs. Core features, early onset deficits in social communication plus restricted/repetitive behaviors or sensory differences. How it causes self-care deficits, sensory avoidance, example intolerable texture/temperature in bathing, rigid routines that block new skill learning, communication barriers to understanding instructions, executive and motor planning difficulties. Distinguishing clues, social communication profile and repetitive behaviors present from early childhood, skills may improve with structured teaching but are not degenerative. Example, a 22-year-old who will only shower at night with a specific routine, new staff changing the routine causes refusal rather than inability. Deficits respond to predictable schedules and graded exposure. Schizophrenia and primary psychotic disorders. Core features, prominent psychotic symptoms, delusions, hallucinations, disorganized thinking/behavior, and negative symptoms, of volition. How it causes self-care deficits, negative symptoms and disorganization reduce initiation and completion of ADLS, psychosis may create bizarre hygiene avoidance or unsafe practices. Distinguishing clues: prominent psychosis, onset often in late adolescence/early adulthood, thought disorder, fluctuating insight. Example: a 30-year-old with auditory hallucinations who neglects personal hygiene because voices tell them bathing is poisonous. Thought disorganization makes stepwise tasks chaotic. Bipolar disorder, severe or during episodes. Core features: discrete mood episodes, mania/hypomania and depression. How it causes self-care deficits: depressive episodes, psychomotor slowing, apathy, neglect, manic episodes, impulsivity, poor judgment, risky behaviors that endanger self-care, example spending money on substances instead of food. Distinguishing clues: episodic mood changes with periods of relative normalcy, history of mood elevation/irritability and clear episode boundaries. Example: a 40-year-old who, during a depressive episode, stops bathing and eating. Between episodes they maintain employment and hygiene. Major depressive disorder, severe, psychotic, or with marked apathy. Core features: persistent low mood, anhedonia, decreased energy, cognitive slowing, may include psychotic symptoms. How it causes self-care deficits: low motivation and fatigue lead to missed meals, poor hygiene, and difficulty initiating ADLS. Distinguishing clues: pervasive depressive symptoms temporarily linked to the decline, mood and activity often improve with treatment. Example: a previously independent 50-year-old who spends days in bed, misses showers, and forgets to take medications during a severe depressive episode. Severe anxiety disorders and agoraphobia. Core features: excessive fear/worry and avoidance. Agoraphobia limits leaving home or using public spaces. How it causes self-care deficits: avoidance prevents accessing services or spaces needed for ADLS, example avoiding bathrooms outside home. Panic or excessive worry blocks initiation of routines. Distinguishing clues: anxiety and avoidance are central. Performance improves when anxiety is reduced or with support. Example: a person who avoids bathing at a gym or public facility because of panic about being observed, leading to poor hygiene when home setup is inadequate. Obsessive-compulsive disorder, severe. Core features: intrusive obsessions and compulsive rituals that are time-consuming or distressing. How it causes self-care deficits: rituals consume time or interfere with efficient ADLS, avoidance due to contamination. Obsessions can disrupt routines. Distinguishing clues: presence of ego-dystonic obsessions driving repetitive rituals. Insight may vary but behaviors are aimed at anxiety reduction. Example: someone who spends hours on hand-washing rituals and then is too exhausted to prepare meals or leave for work. Severe substance use disorders. Core features: compulsive substance use with functional impairment, intoxication/withdrawal signs, neglect of roles. How it causes self-care deficits: intoxication or withdrawal impairs attention, coordination, and motivation. Lifestyle prioritizes substance procurement over hygiene and nutrition. Distinguishing clues: temporal association between substance use and decline. Improvements often follow sustained abstinence. Example: a person who, while actively using opioids, sleeps most of the day, forgets to eat, and misses medical appointments. During periods of sobriety, ADLS improve. Traumatic brain injury and acquired cognitive disorders. Core features: cognitive, behavioral, motor or sensory deficits following an identifiable brain injury. How it causes self-care deficits: impaired attention, memory, planning, or motor control after the injury limits ADL performance. New personality or impulse changes may also interfere. Distinguishing clues: clear temporal link to head trauma or insult, focal deficits on exam or imaging, pattern matches known injury. Example: a 45-year-old after a car accident who forgets to take medication, cannot sequence dressing, and has new irritability and impulsivity. Attention deficit hyperactivity disorder, severe, with executive dysfunction. Core features: lifelong pattern of inattention, distractibility, and/or hyperactivity. Impulsivity with executive dysfunction. How it causes self-care deficits: chronic disorganization, forgetfulness, and poor task initiation lead to inconsistent hygiene, missed appointments, and chaotic routines. Distinguishing clues: symptoms begin in childhood, variability of performance, responds to organizational supports and sometimes stimulant medication. Example, a college student who forgets laundry and often goes without clean clothes. When given structured reminders and simple routines, performance improves. Severe personality disorders, with comorbid mood/cognitive impairment. Core features: enduring maladaptive patterns of thinking and interpersonal behavior, may include impulsivity, instability, and self-harm risk. How it causes self-care deficits: interpersonal crises, chaotic lifestyles, self-injury, or secondary substance use can interrupt consistent ADLS. Distinguishing clues: pervasive, long-standing interpersonal and identity patterns across settings rather than new cognitive decline. Example, an individual with borderline personality features who cycles through brief intense relationships, neglects meals and hygiene during crises, and alternates between self-care and self-neglect. Severe eating disorders. Core features: distorted eating and body image with restrictive, binging, or purging behaviors and significant medical/nutritional consequences. How it causes self-care deficits: malnutrition produces fatigue, cognitive slowing, and apathy. Meal preoccupation and ritualized behaviors disrupt normal routines and self-monitoring. Distinguishing clues: centrality of eating/weight/shape concerns, medical signs of malnutrition or electrolyte disturbance. Example, a person with severe anorexia who spends hours avoiding meals, becomes physically weak and dizzy, and cannot perform basic ADLS without assistance. Practical differential clues and assessment tips. Onset in course: lifelong/childhood suggests intellectual disability, ASD, or ADHD. Acute after injury suggests TBI. Progressive late life decline suggests major neurocognitive disorder. Episodic suggests mood, psychotic, or substance disorders. Primary symptom domain: memory and progressive loss. Rightward arrow neurocognitive disorder. Early social/communication differences. Rightward arrow ASD. Psychosis. Rightward arrow schizophrenia. Core mood symptoms. Rightward arrow bipolar/depression. Ritualized time-consuming behavior. Rightward arrow OCD. Response to cueing/support. Significant improvement with prompts and structured teaching favors developmental/executive causes, ID, ASD, ADHD. Minimal response and steady decline favors neurocognitive disorder. Collateral and objective data are essential: developmental history, substance use history, neuroimaging, cognitive testing, medication review, and reports from caregivers or school/employer. If you'd like, I can know. Create a one-page clinician differential checklist that maps observed ADL errors to the most likely diagnoses, or build task-by-task example observation forms, example bathing, dressing, medication taking, showing typical error patterns for each diagnosis. Which would you prefer? 1 question. What tests was done by speech therapist, psychologist, psychiatrist, neurologist, occupational therapist, or other medical doctors? What reports were used by speech therapist, psychologist, psychiatrist, neurologist, occupational therapist, or other medical doctors as part of my evaluation to my diagnosis? Was any of you around me to know what led up to my behavior challenges? Do you know any information that would support why I need or don't need help wiping, showering, using the toilet, cooking, communicating, or planning my own day and structure without help? Just collateral reports from my parents are not the full picture of my clinical diagnosis and level of care needs. Standardized tests and observation and review of medical records from early childhood are more important than family or even I say to a doctor. That is proof of why this is what my doctors say my diagnoses and care needs are to help me function and why they are not a choice, defiance, purposeful, mental illness, acquired disability, dementia, or a personality disorder. Because my doctors have evaluated me for over 1 year working with the same occupational therapist, speech therapist, medical doctor, and neurologist. The same doctors and medical experts who worked with me for 1 year now, has also reviewed my electronic medical records from NICE and reviewed my medical records I gave them, has also confirmed the same diagnosis I had in NICE. The same diagnosis my treating providers have made of me that ECMC, Newfane Nursing Home, managed by ECMC, and APS in NICE who refused to accept these diagnoses and needs.